welcome to the Keys to Therapy. Today's guest, we have Erica. Hi, Erica.
Hi.
It's so good to have you here.
Thank you. I'm really excited to be here.
Yeah, I'm so excited too because eating disorders is something I really don't know much about except like the very basics, like criteria and DSM stuff that was covered in school. But other than that, I mostly refer out.
Yeah.
So this is going to be good for me to learn something.
Yeah. And you know what? I feel like you are in good company because I remember when I was in school and it wasn't like deep dive, like a lot of information wasn't talked about. So
Mhm.
I feel like you would be in good company with that.
Yeah, I'm sure most of us don't
Yeah.
know
Yeah.
much about it, except again, the very basics. So I'm excited to get into it today. But before we get started, can you tell the audience a little bit about who you are and what you do?
Yes, yes. So, hi, everybody watching at home. I'm Erica Butler. I'm a licensed marriage and family therapist and PhD candidate. Professionally, I'm the site director here at the Renfrew Center. So, we're in South Charlotte and we are an eating disorder higher level of care.
Oh.
So, we have PHP and IOP, which I know we'll get into the
Mhm.
acronyms and what those mean. So, pause on that. So that's what takes up the majority of my week. I also work part-time for Brave Steps. So they are a nonprofit organization also located here in North Carolina that works with survivors of sexual violence. So that's a little bit, my whole life is eating disorders. So it's nice to have a little pocket of something else that I'm super passionate about. And then on a personal note, I am a wife and a mama to a toddler.
Aw.
So that keeps me very busy outside of here and also lots of fun and lots of laughs. So, and then another personal tidbit is that in my free time, you can catch me perusing the aisles of TJ Maxx. I am a total Maxinista. So,
You may recognize a lot of the
yes,
things behind
I
me.
love it. You got good taste.
Thank you.
But so that is me if I'm not shopping, chasing a kiddo or working.
Oh, nice. That's a
Yeah.
good combo. Good work-life balance there.
You know what? Life is it's all balance.
True. Yeah.
Yeah.
And we have to have that as therapists too. So
Yes.
retail therapy is a thing.
It really is.
Yeah. Well, before we get too into some of the questions for the topic today with eating disorders, I want to know a little bit about your journey. Like, why did you become a therapist?
Yeah, it's been a journey. So I always tell people when that I got into therapy because being a therapist because I'm nosy, which is still very true. I'm still very much interested in people and what they've got going on.
Hmm.
But I found myself even in high school taking on a very, I shouldn't have been trying to be a therapist, but I took on that role. I was always giving folks feedback or what do you think about this and just really interested in everyone and their families. So that's why I
Hmm.
became a family therapist. And then also in high school, I really got interested in eating disorders. So it was sort of a random find that I started reading books like there'll be a trigger warning for winter girls. Don't read that if you're in recovery. It's not that kind of book. But
Hmm.
if you're in a good place, that's where I first read a story of a personal account of someone diagnosed with anorexia. And I remember just being really interested in how eating disorders manifest. But of course, I was 17, so I didn't really have much I could do with that clinical interest. So I went to school, and while I was in college in Pennsylvania, I actually had one of a close family friend that needed higher level of care for an eating disorder and went to the Renfrew Center in Philadelphia for residential. So I was probably 19, 20 at that point. And I went to visit her there. And I remember, of course, being there for her and wanting to support her. And I was also like, wow, this is a job. Like
Hmm.
people do this. And of course, at that point, you're trying to figure out, do you want to go to grad school?
Yeah.
What do you want your next steps to look like? So I think that really solidified it for me. So I went on to grad school, got a degree in marriage and family therapy. And then from there, I sort of felt stuck with how I could get into eating disorders. It was always a passion of mine, but I felt like I couldn't really get involved in it.
Mm.
So I did a lot of work, higher level of care with children. So a lot of work with autism spectrum, and a bulk of my career was at a RTF for kids in Pittsburgh. So we saw a lot of different diagnoses there. So I got to work with eating disorders, but it wasn't a primary focus.
Hmm.
I then made the some days a good decision, some days other decision to go back to school around that time. And I decided I wanted my dissertation to be on atypical anorexia nervosa and weight
Mm.
bias.
Wow.
So with that, I decided I really need to get into this work. I have such a working book knowledge of eating disorders, but I want to do the face-to-face interactions. I want to be in a leadership role in an eating disorder facility. And I also needed to get out of Pittsburgh winters. So
Oof.
all of those coupled together,
Yeah.
when I saw the posting for the Renfrew Center here in Charlotte, they were looking for a site director. I was looked at my husband. I'm like, well, I probably should apply, right? And he was like, yeah, go for it. I never thought that it would come to fruition and that we would move up a toddler and a dog and a husband and
Wow.
move here, but we did, and it has been the biggest blessing.
Mhm.
So now I have gotten the opportunity to supervise therapists that have that same interest that I had when I was starting out,
How cool.
and get, you know, to put a lot of that book knowledge into practice and learn so much more than you ever will from a book. So it's been great. So that is my short, long story of how I got here.
Yeah, but I love how you pursued it though. Like it was something like the seed was planted a long time ago, but you were like, no, this is still kind of here.
Yeah, and
I
I
need to
felt
pay
like no
attention.
matter where I went, there is stigma around treating eating disorders. Not everybody wants to do it, and there's ideas about what that looks like. And
Right.
so everywhere I went, when I would take cases, they're like, where? Because the eating disorder girl, she'll work with her. So I sort of got that name without ever
Yeah.
working specifically in that. So I think it solidified for me, especially when you get to start to see those wins of a patient that's really been struggling and you're the one that's put the ball in motion to get
Mhm.
them to take even a step towards recovery. You're like, oh yeah, this is my jam. I want to do this.
Oh, yeah. And I feel like, I mean, I was a teenager in the early 2000s-ish.
Mhm.
So if you think of all the celebrities there and the Lois Rise Jeans and Nicole Rich, everybody's like Paris Hilton, just what that standard was at that point. I feel like at that age, I don't know if we're similar. I think we're around a similar age, but I feel
Mhm.
we're bombarded with that content very young. And that I saw a lot of people latch on to as a teenager. And then I started to read like magazine articles or things that I always kind of knew what it was, but I feel like it was really glossed over in my program, I guess, because
Yeah.
this is kind of all generalist stuff at that point, and there wasn't really a lot of talk about it or opportunity to learn more. So it sounds like you sought it out.
Yeah, absolutely. And I think that's such a good point about the media in the 2000s and what that looked like. And while I think there's a lot of similarities still, of course, fat phobia exists in
Yeah.
all, sectors of the world. But I think that the world back in the early 2000s, growing up in that era, I mean, people were criticizing, um, you know, different celebrities for what they looked like, or, if their body had changed in a certain way, it was plastered everywhere. And I remember, now that I look back on these pictures of these women that they were saying all of these horrible things about, I'm like,
Yeah.
that is you considered someone
Yeah.
like, and how did that impact all of us now as adults trying to make peace with our bodies and our food and all of those pieces? You have to wonder if that is a driving factor to a lot of for our own personal self work and our healing our relationship with food, but also the work that we do with other patients.
Oh, absolutely.
Yeah.
Yeah. And I really don't think it was talked about enough. So I love that, like I said, it was something that kind of stuck with you. And over time, in different settings or whatever else, you still were like, no, this is something I want to do. And then now
Yeah.
here you are.
Here
So
I am. Yeah, perseverance. It'll get you places. It might take
yeah,
a little bit, but you'll end up where you're supposed to be.
that's awesome.
Yeah.
So with I guess you mentioned different levels of care.
Yeah.
So I know typically when I've heard of different levels of care or PHP, IOP, stuff like that, it's almost always been related to substance abuse. I
Mhm.
haven't really heard it discussed very much with eating
Yeah.
disorders. So,
Yeah.
like I said, I'm going to learn something today too, which I'm excited about.
Yeah.
But if you could explain maybe what those different levels
Mhm.
are for care and what they each entail.
Yeah, absolutely. I surely can. So, um, I believe that most treatment facilities do this really similarly, but just for the context of this interview, the only working knowledge I have is from Renfrew. So this is
Yeah.
all going to be from our lens and what that looks like. So we have two residential treatment facilities. And they are in Philadelphia, called
Yeah.
Spring Lane. And then we have one in Coconut Creek, Florida. Could we just call
Hmm.
that Coconut Creek? So those are our two residential facilities, and that is the highest level of care that
Okay.
Renfrew offers. Now there is inpatient, which abbreviation, if you ever see, is IP.
Hmm.
So inpatient would be through a hospital or another higher healthcare facility. I know that the Eating Recovery Center in Colorado, Denver,
Hmm.
has an inpatient facility. But that's the highest you can get. So that would be someone that is severely medically underweight, needs an NG tube to regain nourishment, all of those pieces. Residential is the next step down from there. So, like I
Okay.
mentioned, we have two of those with Renfrew. There's also others in North Carolina, like Carolina House, and Veritas has a location as well. So there's places more local too. Um, and that really looks like 24/7 monitoring and care and support, as well as your entire treatment team being around at all times. So you're not seeing your psychiatrist, just once a week, you're seeing them around. Your medications are monitored and given to you there. So a lot of times, if we have folks that need medication changes, that's a great place to do it because you do have that medical monitoring. All of your meals, breakfast, lunch, dinner, snacks that are incorporated into your meal plan are also all going to be provided there. You have that therapeutic meal support from professionals,
Hmm.
a lot of group therapy, art therapy. They do a lot of family therapy, either virtually if the family's not local, or in person if they're able to get there. They do a body image group every week, which
Oh.
I feel like is very important for recovery as your body is changing with more regular nourishment. And then they do a lot of journaling, a lot of reflection, and then all of the Renfrew programs follow the UT model that the Renfrew Center actually created. That's the conceptualization and treatment of eating disorders. So it's a really fancy way to say that they have taken the best of CBT, ACT, motivational interviewing, sort of morphed them together into this nice little package with a bow, specifically for eating disorders. And I think that it is a great framework for new clinicians that don't, necessarily have the raw skills to treat an eating disorder, have the interest, but they don't know where to start.
Hmm.
A really great way to say, here's the modules. You can spice it up however you like, but here's the framework for what you're going to be doing today. Here's the skills that you're going to be teaching the patients
Nice.
here in the program. So it's sort of a universal treatment language that I thought has been
Yeah.
really nice. So
Cool.
um, that is the residential level of care. And then in
Okay.
our partial hospitalization level of care, so that's PHP. So if you hear me
Hmm.
say PHP, it's partial hospitalization. We do
Okay.
have that here in our Charlotte location, as well as 19 other Renfrew locations across the
Wow.
country. Yes, there is a lot, from Chicago to Radnor, Pennsylvania, to Los Angeles. They're everywhere.
Wow.
Yes, Orlando, Pittsburgh. Yes. So we
Nice.
are around. So our partial hospitalization program is either for, you can get an assessment and come straight to partial hospitalization, or you can step down from the residential level of care. So it goes inpatient, res, PHP, IOP, outpatient would be the T,
Okay.
if that makes
Okay.
sense. Sometimes a visual aid is
Yeah.
helpful.
Yeah.
But partial hospitalization we do have here on site. So the normal structure is it's 5 days a week. It
Okay.
starts at 8:30 in the morning and it goes to 2:30 in the afternoon. We always have two therapeutic meals included. So that's breakfast and lunch. Included in PHP is you meet with a psychiatrist every week. You also have an hour and a half of individual or family therapy a week. So sometimes therapists split that up and they'll do 45 minutes of individual therapy and then 45 of a family session or a couple session or whatever that looks like. And then they'll also have an hour-long individual session with a registered dietitian once a week as well. So that's also
Wow.
included. And we have all of those folks on site.
Oh my
So
gosh.
yeah, so that's really, really nice. So it's a one-stop shop for
Mhm.
all of your ED needs all in one place. And then the rest of the patient's day, when they come in, we always do mindfulness. And I think that that is so important. We know that life sometimes get in the way of putting ourselves first. So I think connecting with your body, preparing to sit down and eat the meal, even if you're feeling emotionally full, sitting down, preparing for the meal, connecting with the other patients, connecting with the team, being present for the day is a really great way to start. I actually wish that I did more of that myself personally before I started to work during the day. Uh,
Yeah.
but so that's how they start. We always do breakfast first, and
Okay.
then we do a lot of different topic groups that switch during the week. So we do have art therapy here on site that we do once a week. Once a month, we have trauma-informed yoga that comes,
Ooh.
which has been a big hit with, and we also do staff yoga too. So after the patients leave the day, then we do staff yoga too, which is really great. You got to have that self-care. And sometimes if
Yes.
I can't get my staff to do it, I build it in for them to their work day.
Love it. That's a
Yes.
good boss right there.
Yeah. So we have that option. Um, Let me think what else we do. We have body image group every single week, also again to talk about, as you know, if a patient has weight restoration goals or whatever that could look like, their bodies could be changing, and obviously that can bring up a lot of emotions that go along with that. We
Yeah.
have UT, which is our framework group that I just mentioned. That's every day from 11 to about 12:15. So that's the hallmark group that never changes. On Mondays, we'll have like a weekend review group
Hmm.
that talks about how did things go over the weekend? How did your meals look? All of those things that check base, touch in. And then the other nights through the week, we'll do an evening planning group. And then
Oh,
on Fridays, we do a weekend planning group.
nice.
So we really try to get in there and plan and do all of those pieces. We try to do some groups outside, get in there. All of our meals are catered.
Okay.
So I think that is helpful to our patients sometimes, sometimes not so much, but I think it is helpful to standardize the serving sizes and portions for folks
Yeah.
on meal plans. And then our IOP program, which is the lowest level of care offered here at our Renfrew facility, is held 3 evenings a week. So it differs
Okay.
from PHP in that it's an evening program and they get dinner support. So it's about 5 o'clock in the evening to about 8 o'clock.
Okay.
And it's really for patients who you can, of course, get assessed at that level of care and come in. Most of the time, we see folks step down from a higher level of care and join our IOP program. So that curriculum is more tailored to where they're at and a little farther along in the recovery process
Hmm.
because it is shorter. So they're sort of at the expectation that breakfast and lunch are more manageable in their recovery to do independently or with a support at home or whatever that could look like.
Hmm.
So IOP has dinner support. They always have the UT group every single night. And then the topic groups will change. So one night a week, there's a nutrition group, which I miss. That's also in PHP too. So our dietitian also leads a nutrition focus group to talk about all of the different elements in food that give us nourishment and why they're so
Wow.
helpful. So sort of to debunk some of that, the age
Yeah.
old carbs are bad myth.
Yeah. The good or bad labels with food and all
Yeah,
of.
so
Mhm.
that's why we have someone with a master's degree in nutrition to come in
Yeah.
and talk about here's what carbs do for your body. They give you energy. Here's all of the facts
Yeah.
about what this food does for your body to support it. So that also takes place once a week in IOP, then an art group, different good things thrown in there as well. And then of course that therapeutic meal at dinner. And then the other option would be outpatient. So then once folks discharge from the Renfrew Center or wherever treatment, higher level of care they go to, we normally refer to outpatient providers. So that's folks that work private practice. That's folks, registered dietitians that work in a private practice as well that are ED informed and trained.
Hmm.
So that's normally where they go next. And then we actually here at Renfrew have a virtual outpatient group that our team leader, Carly, runs once a week on Thursday nights. So that's actually open to folks that aren't patients past or previous, that just want to get connected to learning more about
Wow.
eating disorder recovery. So that is an option too that could supplement, regular outpatient therapy with their therapist.
Wow. So there's
Yeah.
a lot of different levels of care with a lot of different layers to each
Yes.
one. And
Yes.
it sounds like depending on where the client is, there's going to be a resource somewhere in there for them. And at whatever
Yes.
stage they're at, there's a different
Yes.
resource as well. And I like that you guys offer all those different levels because there's a familiarity, I'm sure, with the staff
Mhm.
and the structure. So if you're able to kind of move up or down
Yeah.
within one place, that's going to be really nice for them as far as like consistency of care.
Yeah, absolutely. And I think one of the best things about staying in a provider through the levels of care is that if someone starts off in Renfrew Res, of course their therapist will change, but their new therapist here in Charlotte will have access to all of their records. They
Mhm.
would have had a bridge session with their therapist in Florida and their new therapist here. So everyone's on the same page. I know for a
Yeah.
lot of times folks, when they get a new therapist, like, now I got to tell my whole story again. And I don't want to do
Mhm.
that. So I think a lot of times with the patient's permission, the previous therapist will talk to the new therapist, and the new therapist can say, well, I already know all of that. So let's start off with where you're at today
Yeah.
and how that's impacting your functioning and your recovery. So I think that's one of the great pieces about continuing in a treatment facility.
Absolutely, because
Yeah.
I know I've had struggles with trying to get a hold of, like, past therapists or the
Yeah.
psychiatrist especially. I
Oh,
can, like,
yes,
never
that's a
get them
whole
to call
treat.
me.
Yeah.
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 So, I'm like, "Guys, I'm important too, like, call me
Right.
back."
Like, love me back. I need help.
Yes, like, we could be a team. So, I'll let you be Batman, I'll be Robin, it's fine. But they won't call back a lot of the times. So, I feel like at least even if it's in different locations, you guys are all still under this umbrella of Renfrew. So,
Yeah.
there's still going to be maybe, like, similar records, similar ways of doing things also, because I've seen people get a shock to their system when they've been in one level of care at one place and another at a
Yeah.
different place, and
Yeah.
it's almost sometimes like starting over depending on how different it is.
Yeah, absolutely. Because, treatment facilities, while they're all out there to do really great work, can look very different. Their
Mhm.
philosophies from nutrition to therapy can look very different. So we've
Yeah.
had patients come to us for a variety of reasons from different facilities. And it's been a really difficult transition a lot of the times because things just look really different depending on where you're at. The language is different, the
Mhm.
day structure is different, the food is different.
Yeah.
So it can be difficult. Necessary sometimes to swap if you do feel like, of course, it's not a good fit for whatever
Mhm.
reason, but it can still be a challenge for folks.
Yeah. Well, I'm curious about what the therapeutic meal support looks like.
Yeah. So that I think I always say it's the most important piece of what we do. And I mean that because it's fun for us because we get to eat
Yeah.
alongside of the patients. But I think it always starts with a check-in. So we always start going around the table. We have a dining room here on site. So we go around the table and all of the folks their meals are set up.
Okay.
They're ready to go. Um, they don't have to worry about plating, or if they are in a place in recovery, we do have intuitive eating opportunities where the patient can work on identifying what a portion would look like to meet their specific meal plan. But most of the time, we're plating the food, for the patients.
Okay.
And we always do a check-in. So talking about meal intentions. So, what are you coming into this meal with? What's your goal here? A lot of times we get complete or whatever, whatever that goal is. Or we do get to enjoy, to be present a lot of
Mhm.
times, to eat this mindfully, to not mechanically eat. Or we have some patients, I'm working on my pacing. So whatever sort of term or whatever, word they want to assign to their goal. And then we go ahead and we get started. So the meals are 45 minutes long with a 15-minute check-in at the end.
Wow.
So we go ahead and we get started, and it's sort of modeled after what a traditional break at work or at school would look like so that patients can get used to pacing into the real world and make sure they're nourished even when they leave. So we go ahead and we start eating. So all of the staff eat alongside of the patient.
Mm.
So I think that that's really important to normalize
Yeah.
nourishing your body and seeing someone else eat and complete the meal alongside of you. So we do a lot of different meals. We have bring your own day, which is always an exciting one. The patients can bring in, as long as it meets the meal plan components,
Mhm.
they can bring in, either they can get Panera on their way in, or they can bring a turkey sandwich from home, or whatever they have been wanting that maybe we don't regularly offer in program. We do pizza day, which is a fun day for staff, but also a challenge for
Yeah.
everybody. And then we do burger day from Smash Burger. We do Jimmy John's. So we try to make it, we do operate under an all foods fit philosophy and a health at every size philosophy. So I think when
Nice.
talking about meal plan, that's important to remind folks and get folks knowing those terms. So that really means that we really do believe that all foods fit under a well-rounded diet. So dessert when you want
Mhm.
it, it fits into a diet. Jimmy John's, Panera, all of those things are a necessity in life, and it's important to sort of incorporate them in recovery. So that's a little bit about that philosophy. But once the patients are eating the meal, we're regularly sort of checking in. So we normally have two, depending on our census, how many patients are in program. We always have a licensed therapist, but sometimes we have two. So right now we have two therapists just because we've got a higher census. So we'll sort of check in throughout the meal. If we see someone taking some time or maybe
Mm,
avoiding through conversation or moving around their rice on their
yeah.
plate or just anything coming up struggling, we will check in. Hey, just notice that maybe something's coming up, what's going on. And that a lot of that will happen through the meal. And then following the meal, well, we always give a halfway point, sorry, so we
Okay.
always let the patients know, hey
Nice.
guys, just looked at the clock, we're about halfway done with the meal today. And that allows folks that are chitty chatty to be like, okay, no, no, I'm
Yeah.
gonna
I
finish
gotta
up my
eat.
meal, or those that are really working on pacing, if they've, been trying to make sure that they, don't eat it all in 5 minutes and they can space it out a little bit or whatever
Mhm.
that looks like for them. Um, and then at the end, we always save about 15 minutes for what we call A&A, is awareness and acceptance.
Hmm.
So we go around and we talk about how the meal was for them. So,
Okay.
what came up for you during the meal? What was your distress? How did you feel going into the meal? How do you feel coming out of the meal? Do you need a check-in following? Can we talk about this in your individual session? So really just checking in. A lot of times, patients will say, I came in at a 5 with the distress scale, and now I'm leaving a 7 because I'm physically very full, and the feeling of fullness can be very
Yeah.
overwhelming for a lot of our patients. Or I came in a 5, I was terrified of pizza, and then I'm leaving a 2 because I really enjoyed it. So sometimes you get a mixed
Yeah.
bag. So that's how we do it every single meal. So
Okay.
breakfast, lunch, and then we do it again at dinner with our IO peer. So our folks, they know it's coming. They get very into a routine, and then they also fill out during the meal what we call an FEJ. So I know all of you watching are like, oh, the acronyms, but mental health. So that's our life at this
Yeah.
point. So an FEJ is called a food emotion journal.
Okay.
The patients, it looks like a fancy Excel spreadsheet with lots of prompts on it. And what the patients do is that every meal they follow the prompts so they can be talking and engaging, but it's a really sort of introspective way to document what's coming up for them. And then they also, once they're done with it, they turn it in to our staff. Then
Oh,
we
okay.
have it, and then we can use that as a tool to prompt conversations an individual with the dietitian or with the therapist or whatever that looks
Mhm.
like. So the patients are filling that out. Avocado, the texture is not my preference, or I'm really struggling with this dessert today. Whatever's coming up for them, because we know those feelings can be fleeting. So if they don't write them down in the moment, and then we try to talk about it in session, they're like, I don't remember. I think it was hard for me, but I've eaten 5 breakfasts since then, so I don't remember.
Yeah.
So it's really, really important to do that work and to have that. And then we also, in terms of meals, we have an RFID meal that is really important. So RFID is sort of new and upcoming in the eating disorder world, with lots of research sort of bursting out on the scene. So we
Huh.
actually have RFID programming here. So what that really looks like is a bunch of tasters. So we actually have RFID programming that's virtual and in person to connect with other patients in across the Renfrew system, versus there might be one or two patients in person, and then
Mm,
you can connect with a lot of people globally. So when an RFID patient comes, we normally have them do a hierarchy. So that's talking about fear foods versus safe foods. So like, what are
uh,
your foods that you're really comfortable with? Let's talk about those first. Is it chicken nuggets and mac and cheese, or what are you really safe with, and what is like an absolutely not, I never want to see this, celery is terrifying, or whatever that could be. And then we sort of start going through the list, starting with things that are a little scary, but maybe we can do a taster in the RFID lunch. So that means if strawberries are, it makes my palms sweat, but I think I could look at a strawberry. I think I could be in the same room as a strawberry. So a taster is not included in the meal plan. So all of your nutritional needs are being met in these other components. So
Mhm.
there's no need to eat the taster. So it's really
Ah,
just there to smell, hold, lick, take a bite, just be in the space of the new
mhm.
food. And then whenever, ready with some therapeutic coaching on that end, if they want to take a bite, they're more than welcome. So that's really how we start to work with our fit. So not to get on a segue tangent, sorry.
No, no, but it's like exposure therapy. The way you were describing it, it's that just with foods.
Yes, yes, it's very, very slow, controlled, and
Nice.
trauma informed exposure.
Mhm. I
Yes.
like that. Yeah, I feel like that is going to be less intimidating for people, and I'm sure it's like you were saying with the levels of care almost, it's sort of like, let's work up to these levels of combating that fear.
Yes.
So talking about it, getting them slowly accustomed to it, because who knows what'll come up in social situations or in the real world, and you want them to be prepared for that.
Right. We also want all of our patients to be able to get out into the world and to live. Food is so intertwined in our culture. So we
Yes.
want to have folks be able to go on an anniversary dinner with their partner or go to the mall food court with their best friend on the weekend. We
Yeah.
want folks to be able to live. So doing those little pieces to inch towards being comfortable in those situations can really mean a lot.
Oh,
Yeah.
definitely. So, yeah, there's so many different services there that are
Mhm.
incorporated. I'm like, wow, it's
Yeah.
like a lot. That's the most comprehensive I think I've ever heard.
It is very much comprehensive. And another thing I
Wow.
actually missed when we were talking about exposures
Yeah.
is in our partial hospitalization and intensive outpatient program, we also do outings, therapeutic outings, exposures.
Oh,
And those are really exciting and awesome to watch. We go to the mall and sometimes we do a clothing exposure. So trying on clothes, as we know, when our bodies change, it can be very overwhelming to try on clothes in a different size number than maybe we had wanted to be in or we're expecting to be in. And then also eating in the food court. We do outside dessert exposures. We have a Ben and Jerry's, which is like my best friend, and it's right here. They know me by name.
that's
Um,
awesome.
but we take the patients to Ben and Jerry's to practice ordering on their own, honoring those food preferences.
Mhm.
Are we picking peanut butter cup like we wanted, or are we picking frozen yogurt because it's the lower
Yeah.
healthier. So honoring those food preferences. We do so we those are my favorite outings are the
Mm.
mall outings. We also do grocery shopping outing.
Oh, I love this.
Yeah, so grocery shopping can be super overwhelming. I think for a lot of people. Sometimes I go through the grocery store, I'm like, it's a lot of work.
I have
Um,
a list
so
every time.
yeah, so especially for our patients being
Mhm.
surrounded by foods that could potentially be very scary or relating to trauma or whatever that
Yeah.
could look like. So we do grocery store outings with normally with our dietitian does those.
Nice.
And we go through and we talk about different components that we can select to then go ahead and make a meal. So if you were here and this was your meal plan, what would you get that would meet all of your exchanges of the meal plan? What would you buy here? So it's really helpful and it's sort of preparing folks for yes, your meals are catered in here at Renfrew, but eventually you are going to have to fly on from us and
Yeah.
probably if you can get it Instacarted, but eventually you're probably going to have to make your way
It's
back into a
expensive.
Publix at some point.
Yeah.
And how can we still get our needs met
Mhm.
there? And how can we shop and follow sales and all of those things depending on folks' needs. So sorry to get on another tangent, but
No,
when we
no,
talk
but
about
I love it.
exposures, I'm like, oh, that's another one.
Yeah, but again, talking about comprehensive, that's even more comprehensive. And I
Yeah.
like that it's practical skills
Yes,
too,
very
because
much.
I know most people, especially depending on your status, privilege, family, money, whatever else, they might not have ever learned much about,
Yes.
what is food, healthy eating, would not except like the food pyramid or
Right.
whatever.
Stuff
Like
that no one makes sense to nobody, right?
no, when it's,
Yeah.
like, been proven false anyway. So, like, there's just,
Yeah.
like, so many things that we weren't really educated on
Mhm.
young, and so I feel like it's for a lot of people, it's probably brand new information, and
Yeah.
that's a lot to not only take in, but then put into practice. So if
Yes.
you guys are there to help ease that transition from, "Here's all these new things you're learning in a
Mhm.
safe environment, how do we set you up for success outside of here?" You're making that bridge for
Yes.
them.
Yeah.
So great.
Yeah, and then a lot of times too, we have patients that their culture or religion will
Mhm.
impact the food that they choose to eat. So I
Yeah.
think that's also something that we work really great with. We've had a variety of kosher patients come in and working with them to identify places that they can get kosher foods that
Mhm.
also nourish their body is really important. Talking to a lot of folks around like the Ramadan time about
Yeah.
fasting and what that
Mhm.
can look like. So I think that's really important too, to take the work that you do here and apply it to real life, because otherwise it's great in this therapeutic environment that we've created. But if you can't do it at home with your family or at church or in a synagogue or whatever that looks like, then
Yeah.
it's really not effective.
Absolutely, yeah, and I know therapists say, like, we're supposed to work ourselves out of a job, essentially, right? Like, get
Yeah,
people better and
right.
help them get better, so I feel like, yeah, you probably it probably decreases the rate of readmittance to certain
Yes.
programs because you guys are setting them up for so much success on the outside and literally going with them to do these
Yeah.
day-to-day things that they're gonna have to do anyway. Even when you were talking about Panera or Jimmy John's, like,
Mm,
not just putting them in a hypothetical situation, but going, okay, what here can we order? So they already have their orders set up for places that they may meet
right.
friends at or whatever else.
Yeah, yeah. And how do we meet the meal plan that we have talked about a million times in program?
Yes.
How do we, if it was just you here, what would you pick to meet that? Can you count out the turkey and as the protein and the
Mhm.
cheese as the dairy? And how could you make that work while honoring your food preferences?
Yeah, that's
Yeah.
so good. I really like that.
Yeah.
So, what do you think? So, that's like the levels of care and some of the
Uh-huh.
things that go into it. But
Mm.
what are some of the unique challenges that this population faces? Because I know that there are certain things with anxiety or depression, certain things that kind of all can correlate with the different populations, but I feel like this one is very specialized. So, I'm just
Yes.
curious what that looks like.
I would say the hallmark of eating disorders that can be a special challenge for this population would be isolation and secrecy.
Mm,
So I think that the eating disorder voice really strives to have its person keep this to themselves.
mhm.
So we see a lot of patients that are very isolated. They don't want to tell their families. They don't want to tell their partners. They don't want to talk about it. It's just the eating disorder wants to keep it between them. And
Mhm.
the eating disorder has also been, in a lot of ways, their best friend to cope with difficult emotions. So the thought of telling the world about this eating disorder that's been your best friend and potentially losing that comfort and that coping can be very scary for a lot of patients. I think there's also a lot of shame in our world about mental health, as we all
Yeah.
know that they're listening and talking. We all
Yeah.
know that there's a lot of shame associated. I also think that there is a lot of stigma about who gets eating disorder treatment that I think
Mhm.
can very much impact marginalized communities, communities of color. I think women in larger bodies are often feeling like I don't have an eating disorder because I don't look like this person that I think I should have an eating disorder. Insurance is another challenge that we face. There is a whole idea of not being sick enough to receive treatment or having treatment covered by insurance. I think we do really good work doing clinical for insurances to cover level of care, but of course we run into barriers that way with insurance having an idea of what an eating disorder looks like, and we know that an eating disorder looks like anybody.
Absolutely.
So
Yeah.
I think coupled with all of those things would be my main challenges of folks that, they come in and this is their issue, is they feel othered or they feel different.
Mm,
Um, and then the secrecy, I think, creates the biggest. And then the other thing I would probably say too would be that ambivalence that I sort of referenced with having the eating disorder voice be your best friend. I
mm,
think that also creates a bigger challenge for our clinicians to find that internal motivation, because the eating disorder for their whole time has been the only way that they've been able to manage these
mhm.
difficult emotions. So without it, the patient often feels like there's nothing, or they symptom swap. back
Yeah.
and forth to manage the emotions. So I think finding that internal motivation for recovery can be really difficult, because it's, if you don't find the symptom underneath, it's like if you have a sore throat and I give you Tylenol, the pain might go away, but the sore throat's still there
Yeah.
because we're not addressing the root of the problem. So I think really getting to the root and the internal motivation can be tricky in eating disorders.
Oh, for sure. That makes
Yeah,
sense.
yeah,
And one thing I've always said with clients who have maybe had eating disorders, or more so like I guess in a clinical setting, has been that in for my conceptualization of it, it gets thrown into, I guess probably because it's very similar to substance abuse, because there's a lot of what you just said that matches that, right? Some of the shame,
yeah,
coping skills, things like
yeah,
that. But this one, I feel like eating disorders can be very difficult to treat if you don't have the right type of training, because I feel like there's probably a lot of therapists who have done more harm than good.
yes,
I mean, because at the end of the day, you could say, like, well, you don't need to drink, but you don't need to smoke, you don't need to use, but you
right,
have to eat.
yes,
So I feel like eating disorders are very tricky, even not that the other ones aren't, but
yes,
they're all choices. And I think they're not necessities to living.
yes.
Whereas sometimes,
Food,
yeah.
we gotta do that. And I think one
Yes.
of the most important things that I always tell folks, if they're looking for an eating disorder provider outpatient level, I love Psychology Today and all those websites, and you can check off any box you want. I could be Erica Butler, EMDR, trauma
Right.
certified, when I am certainly not. So I
Mhm.
think it's really important to look out for those folks that have worked in a higher level of care eating disorder facility at one point. They have their certified eating disorder specialist designation, or something that can show that they've done this work.
Yep.
And also for folks wanting to get into this work, it's really important that you've made peace with your body and food. You've worked on your own fat phobia, your own internal weight judgments and bias before sitting across from a patient and trying to work through some of that, because we know that our stuff gets in
Mm.
the way. And if that stuff hasn't found its own appropriate home, it's going to come up and it's going to negatively impact the patients that we work with. So that's one of the
Oh,
biggest things I think for a lot of young therapists that want to get into eating disorders. All of my team has a therapist, including myself. So I think that that is super important. Someone that you can talk about when this stuff
mhm.
comes up. How can I manage this in the room? Because it's going to. We're going to find
Yes.
ways. We all have body image things that come up no matter where we're at in our journey with food. And some folks could potentially be in recovery themselves and then go to school and become a
Yes.
therapist. So making sure that before you are doing the work that you are in a really solid place in your recovery
Oh
too.
my gosh, yeah, because I can't even imagine how triggering that would be, especially when you have somebody parroting back some of the thoughts you may have had
Yes.
yourself about your own body, and that's what
Yes.
they're struggling with. So you really don't want to be like, me too,
Me
and
too.
jump into that with them.
Yeah. Yeah.
So you also don't want to take that home.
Yeah, and
And
it's also, I think, always something that we talk a lot about in our clinical group supervision that we have once a week here as a team, about food judgments,
mhm.
how we talk about food and how that really matters and impacts the patients, and making sure that we are talking about food from a very neutral lens. We can have food preferences, but we always say here at Renfrew, don't yuck my yum, which is always just really funny to say.
Yeah.
But people have food preferences. We do not talk food judgments from a staff, and we really want to walk the walk. So even I always think it's interesting because even in our fun team events that we do, none of it is weight or body talk. I mean, we all very much walk the walk on making sure that we try to show up differently for ourselves and for our patients than folks that maybe aren't eating disorder trained, if that makes sense.
Mhm. Oh yeah, absolutely. And these are more open discussions that you guys are able
Yeah.
to have because you have to
Yeah.
this type of setting, not only with the clients, but with each other as well.
Yeah. And then talking about how, patients will look at your body as a
Yes.
clinician. So that's another important thing for anybody interested in going into eating disorders. Patients will comment on your body positively, negatively. a lot of different ways.
Mhm.
And there's a lot of comparison that happens. So again, that making sure that you are in an emotional space to be able to either have a solid sounding board with your own therapist or whatever that looks like for you. Because of course that could be taken very personally and could be very, very harmful if you're not in a good space.
Yeah, I mean, gosh, it could be if you are.
Yeah, right. I
If
mean,
you
even if
are.
it's like, oh, me.
Yeah.
So it could be
Oh,
really difficult to talk about and
yes.
also be in a point where you can objectively talk about what that's like to be in a relationship with your therapist, with their body being larger than yours, smaller than
Mhm.
yours, whatever that may look like, being able to
Yes.
talk about how that's impacting the therapeutic relationship
Mhm.
can be a tricky spot for clinicians, including myself. It's not always an easy conversation to have.
No,
Yeah.
and like you said, we all have our own stories, our own issue body image things. I mean, there's days that I think everybody wakes up and you're like, "All right, I'm feeling myself today."
Yeah.
There's other days you're like, "Oh God,
Yeah,
this
struggling.
I don't even want to wear real pants or whatever's
Yeah,
happening."
right.
So, yeah, you've got to be really aware, and it sounds like having a good support system is huge too.
Yeah, absolutely.
Great.
Yeah,
Well, for new clinicians or really any clinicians, honestly, who are wanting to get into this
yeah,
area, what do you think that they should do to increase their knowledge of eating
yeah.
disorders?
First of all, do it. If you're interested in eating disorders, we need more people. We
True.
need more clinicians to really be passionate about the work. COVID-19 really did a number on
Oh
our eating
gosh.
disorder population with the isolation and all of those things that came up. So we really need more passionate and competent clinicians. So if this is something that you're interested in, please give it a shot. Don't let the stinkies on Reddit scare you off or whatever that looks like.
Trolls.
It's really, yeah, it's really a great field to get in. So one of the first things that I would suggest um, would be to find a friend that works in higher level of care.
Okay.
So find a friend, even if you're an old pro at mental health, find a friend in case you ever do work with a patient or if you want to try working with eating disorder folks. And if they have to make that step up to higher level of care, you know Erica at the Renfrew Center, you know a dietitian that works in eating
Yeah.
disorders. So having those folks even to, do some case consultation with, to talk about things with can be really, really helpful. The other thing I would suggest if you're interested in eating disorders, get involved with IADEP. So it's the International Association of Eating Disorder Professionals. We
Okay.
have one here in North Carolina. It covers the triangle and then also Charlotte's included. And that is a great way to meet all of the eating disorder professionals. And other shameless plug, I am the chapter membership chair. So if you are interested in joining, you already know me there too. So
Perfect.
yeah. The Renfrew Center has a ton of great learning opportunities. So we have the Renfrew Center Conference every single year in November, which is just an absolutely fabulous resource. I think you get like 50 CEUs.
Oh my gosh.
So you can get your whole two
You're
years worth
good.
of CEUs in like a swoop, and it's all eating disorder focused, and it's also
Mhm.
all relevant to what's happening in our world, which I think is really great. So it's
Very
very much
interesting.
handpicked to be super relevant with what we're dealing with. Um, Let me think of some other things. We also have the Renfrew Center Foundation has its summer school series going right now, and it's all virtual.
Oh,
Some of them are free, some of them cost, but they're all on the foundation's website. So you can actually sign up for those, watch them on your leisure. We have a lot of really great different topics if you're working with a patient with a specific diagnosis or whatever that looks like. And then the Center for Recovery for EDs is North Carolina's only nonprofit eating disorder center. So
well,
that is another great way for so CRC for ED is North Carolina. I know Simone, she's the executive director. She's wonderful. So their website is also a wealth of information to find out
okay.
resources, different contacts, all of those pieces. So those would be my things to start. And then social media wise,
Mhm.
one of my favorite, the Renfrew Center has a great Instagram. But some of my other favorite sort of platforms, specifically on podcasts, is the All Bodies, All Foods podcast. So
Ooh.
it's a really good one. They have a lot of good topics. So it's great if you've got a long commute like me through Charlotte traffic.
Ooh.
Sam, I'm looking at you.
Yeah.
It's really great if you've got to be in the car for a little bit and have some time to listen. I think it's been really helpful too. So those are my plugs.
I love that though,
Yeah.
because again, we need to know the resources. There's too many
Yeah.
things out here that aren't vetted or
Yeah.
aren't really giving the best information.
Yes.
And I think it can be really tricky sometimes to figure out what's a credible source and what's not.
Yeah.
So I feel like you gave a lot of different options, whether it's to listen, to watch, to go to. So
All of the
I love
things. And I
it.
actually forgot the resource that I do.
Yeah,
So another shameless plug for me
go for it.
is I facilitate along with my colleague Lauren Pendleton.
Hey,
We facilitate a consultation group for therapists once
wow.
a month. It's virtual. And it's basically if you're working with an eating disorder patient and you just want to bounce some ideas off some fellow therapists, myself and Lauren, and we also have a dietitian, our director of nutrition services
Nice.
joins in, so you have a dietitian at your fingertips as well. So that's once a month. So if you're interested in that, you can reach out to me and we'll definitely get you the link. But that's another really great free resource to join.
That is
Yeah.
awesome.
Yeah.
Yeah, so many things.
I
Like,
everything we've got we've got it
yeah.
going on. Yeah.
I love it though,
Yeah.
because again, I feel like this is something that there wasn't a lot of formal education on.
Yeah.
And I think for most people, even throughout, unless they interned somewhere specifically, they knew right then and there, this is what I want to do.
Yep.
You're not really exposed to much with eating disorders until all of a sudden the client's in front of you and this is something that comes up for
You're
them.
like, oh boy, what do I do?
Yeah, and
Yeah.
it could be months in. I mean, that's happened to me where it's been months in and I'm
Yeah.
like, "Oh, okay, this has been under the surface." Now that we got through some of like the day-to-day things or stressors or started building skills, now this other thing's coming to light. Or the other thing I've worked a lot with is the partners or family members of people who have someone there that is struggling.
Yes.
So that's been really interesting too, because
Yeah.
it's like by proxy, but I need to know enough to
Yeah.
help the partner. So there's
Yeah.
been a lot of self-education, but I like that there's all these different
Yeah.
options out here because
Yeah.
people like me need places to refer people to who have the right training.
Yes, absolutely. And for our families, we actually have a multi-family group that we facilitate once a week. So that's patients
Oh,
and their people all in one room to talk.
okay.
So that's it can get full. And then
Yeah.
we have a support persons group that we facilitate once a week that is just for support people. So no patients involved. So it's a really good space to talk about this is hard.
Mm-hmm.
Hard as a partner, as a parent, as a whoever. This is really hard. And then we also offer support person services for families or family members that want to get their loved one involved in treatment, but they don't want to.
Mm.
So it's about 3 sessions. You also know the facilitator because it's me. So I facilitate them here either in person or virtually. So we basically just talk about the function of eating disorders, what our program looks like, the model, try to, sort of debunk any myths and get that person engaged in treatment. So that's always an option too.
I love that because then that's again, that's full service. That's not
Uh-huh.
just for the client. You're looking at
Uh-huh.
the whole system.
Yes, yes. You know me, family girly. We gotta get,
Yay.
gotta get the parents and the partners in there too.
Again, so grateful for that because family sessions are not my fave.
Oh, you know
So
what? I love it, but it can be
it's a
it can
lot.
be an experience. Yeah.
Yeah. I've had some great ones, and then I've had some that I'm like, "Oh, the door's slamming again." Okay.
Yes. Okay. All right.
Yeah. So, virtually, it's more like they're clicking out now.
They're
But
they're
still,
leaving.
yeah, it's less of an impact, but it still is there.
It still hurts. Of
Yeah, so I'm really glad that there's, again, people like you out there that are taking on these
course.
different things, and I feel like for new therapists too, like you mentioned, there's a bunch of different resources that they can go to. There's lots of places that they can get that education. Sounds like networking is a big thing too. Start getting
Mhm.
to know people within it, to ask those questions, to see how far you want to pursue it or which ways to pursue it.
Yeah.
And if nothing else, then know who to network with for referral purposes. So
Exactly. Because it's bound to come up. So even having a few people, business cards in your pocket of folks that you can reach out and call and refer to is going to be a big help if it's not your
absolutely.
jam.
Yeah.
Yeah.
Well, I know you already gave a ton of tips. Is there anything else that you could think of that maybe I didn't ask about or we didn't cover?
No, that's okay. Let me try to think of anything. I think that the only thing that I always try to make a point of is that no matter the diagnosis, all eating disorders have the same function, and
Mm,
it's to manage difficult emotions. So no matter the symptoms, no matter anorexia, bulimia, ARFID, binge eating, whatever it looks like, it's all a way to manage difficult emotions. And I think sometimes that gets muddied with
yeah.
we treat eating disorders no matter the diagnosis in a beside ARFID because we take a little special approach to that one, but all of the other diagnoses we treat exactly the same.
Mm.
So our binge eating patients are with our anorexia and atypical anorexia patients. So we treat them all the same because we have the understanding that it's the purpose is the same no matter what the symptom looks like.
Yeah, and I think that's important for people to recognize too. And maybe even now that you said that, an assessment question for therapists to
Oh,
be asking, right? Like, what's your relationship with food?
yeah.
Because I've never seen that on a traditional assessment or intake form.
Yes. Yes. And I think one of the things that we offer too is free assessments. So if
Mm,
you do have a patient that you're like, maybe just get this checked out by someone that does this.
yeah.
We can schedule an assessment. They can come in, they meet with a licensed therapist for about an hour and a half, 2 hours, get a full rundown of their history, their current functioning, what that looks like, and then we'll make a recommendation from there. Sometimes we'll say, it doesn't really seem like there's an eating disorder right now. So let's refer you to mental health or back to your outpatient team or whatever that looks like. Or we'll make a level of care recommendation, that IOP, PHP residential tier that we talked about. So that's always an option too,
Yeah,
to get a second opinion if there might be, something underneath there that you're not sure of.
absolutely. That's so
Yeah.
cool
Yeah.
that you guys do that.
Yeah. Yeah.
And I do need to come visit for real.
Yes, you
Honestly.
really do. You really need to come see us so you can see the dining room. And I talked about you'll
Yeah.
actually see my office and all of the things. So come visit.
Yeah, that would be really cool because I'm like,
Yeah,
gosh, you guys are doing such amazing things. I
yeah.
want to get in on that somehow. I want to see what's
Come
going
check us
on.
out. And hey, there's a Home Goods right down the street. So we
Uh,
can, hey, so
yeah, I know exactly. It's by that French bakery. I
yeah,
go over
always.
there.
They know me by name too. So hey, if you come a little close to the time I'm done for the day, we'll give you a tour and then we'll
We'll go do another. We'll do some coping skills after that.
please, we'll buy some goodies at Home Goods and get some
Yes.
macarons for the day.
I'm loving this
Yeah.
plan. Perfect. Well, thank you so much for taking the time to do this today.
So much fun.
Yeah, and I feel like there's so much I learned. I didn't know there was this many levels of care. Again, I've only ever heard it with substance abuse.
Yeah,
So
yeah,
I'm like, why not apply this model to
yeah,
different places? And you guys even have extra layers to it, which is so awesome.
yeah,
But but yeah, for anybody who wants to follow along, I'm gonna put all of Erica's info below so that way you guys can see what Renfrew's up to, what she's up to.
yeah.
And if you want to subscribe, then you can follow future episodes and stay on top of it. But other than that, I will see you guys next time. Thanks again, Erica.
Thank you.
Bye.
Bye.